Good afternoon. Thank you for joining me for this webinar today. The McMaster Health Forum has been working on this concept or this approach of rapid learning health system for approximately 2 years. And over the past 2 years, we did multiple projects, including 2 rapid syntheses, one specifically about rapid learning health systems in Canada. And we're currently also supporting the Ontario Health Reform, and the Ontario Health Reform is currently trying to bake in this approach of a rapid learning health system in the creation, for instance, of their Ontario health teams. So for the next couple of slides, I'll try to share some of those insights from the rapid syntheses projects that we did over the past 2 years, but also some of the work we have done in Ontario more specifically. But just to put you back in context, about a decade ago, the Institute of Medicine in the United States started to do a lot of events, a lot of workshops, conferences on this idea of a learning healthcare system. And back then, it was a system, it was defined as a system that in which science, informatics, incentives, and cultures are aligned for continuous improvement and innovation, and with best practices seamlessly embedded in the delivery process, and new knowledge captured as an integral byproduct of the delivery experience. So back in 2007, they led this workshop on learning a healthcare system, and they said, well, if we want to create a system that can learn rapidly, what is needed? We need to adapt the pace of change. We need a stronger synchronicity of efforts. So we have so many initiatives underway, but how can we better align them? We need a culture of shared responsibility. We need decision support systems. We need electronic health records and so on. And among all those needs, there was also a need for greater public engagement to support a learning healthcare system. If we look at how they defined public engagement back then, it was defined very narrowly. So it was mostly a way to improve communication about the nature of evidence and its development, and also the active roles of both patient and healthcare professional in evidence development and dissemination. So it was really, for them back then, it was really about engaging them in developing research evidence, disseminating research evidence, and so on. So that was about a decade ago, but more recently, this idea of a rapid learning health system took root in Canada. A lot of initiatives around the country, from Ontario to Alberta to New Brunswick and BC, and also initiatives at the pan-Canadian level about trying to implement a rapid learning health system. So it's in that context that about 2 years ago, we were approached by the CIHR Institute for Health Services and Policy Research, and also the Research Alliance on Health Services and Policy Research in Canada. And they approached the McMaster Health Forum and they said, well, could we explore how the concept and the approach of learning health system could be adapted and implemented in Canada? So when they approached us, the decision was made to first, to do what we called a rapid synthesis, which was done over a 90-day period. So the rapid synthesis was focusing on a number of issues, including how can we foster the development and consolidation of learning health systems? And also, what are the assets and gaps that we have in Canada, and especially in the 14 Canadian jurisdictions for creating learning health systems? And another big question that the group had was, are there any interdependencies and issue-based commonalities among jurisdictions that can be used as focal points to facilitate pan-Canadian collaboration? We know that sometimes doing collaboration in a large country with multiple jurisdictions like Canada can be a bit challenging. So was there any interdependencies, any common challenges that we're facing that we could use as focal points for pan-Canadian collaboration? So, as part of the Rapid Synthesis project, we first created an advisory committee composed of representatives from the McMaster Health Forum, but also from the Canadian Health Services and Policy Research Alliance Learning Health System Working Group. So, they had a working group with representatives from across the country that were really interested in pursuing this idea of rapid learning health systems. We then conducted a rapid synthesis of the literature to better understand the concepts, the frameworks, and to find any other relevant studies related to rapid learning health systems. But again, the literature is still fairly limited. There's a lot of editorials, analytical reports, not so much reviews or studies examining the effectiveness of rapid learning health systems. So we wanted to complement our literature review with interviews with 50 key informants from across the country. And we try to find in each jurisdictions policymakers, managers, professional, researchers, other types of stakeholders, and especially patient partners or patient advisors that could provide us their insights about their specific jurisdictions and their thought about the rapid learning health system. In addition to the literature review and the key informant interviews, we did a scan of the 14 Canadian jurisdictions, meaning the federal government, national and pan-Canadian initiatives as well, along with the 10 provinces and 3 territories, to see what are the big assets and gaps that we currently have that could be leveraged to support a rapid learning health system, or gaps that must be addressed if we want to implement and develop a rapid learning system. So that's the project in a nutshell. And based on this experience, I'm going to share with you my top 10 insights about rapid learning health system, but specifically in the context of citizen and patient engagement. So I'm just going to start with just listing these 10 insights, and in the remaining of the presentation, I'll go in a bit more detail about what they mean exactly. So the first insight is that a rapid learning health system must be anchored in the needs, perspective, and aspiration of patients. And you'll see I put a little asterisk next to patient because patients means a lot of things. And for the purpose of the report, we use the concept of patients, but we also included citizens and community members and caregivers. But I'll get to that in a moment. My second insight is that engagement efforts must be deployed at all levels. So it must be deployed at engaging patients and caregivers and other actors at the micro level, so meaning with the provider interactions, at the meso level, more at the level of the healthcare organizations, but also at the system level, at the macro level, and even at cross-sectoral levels. Third insight is that we need everyone to make it work. So most of the literature often focus on patient engagement, but we'll see from this project, but also from what's happening in Ontario, we realize that there's a need to develop initiatives and activities and mechanisms to engage patients, citizens, community members, and family members and caregivers. The fourth insight is that the rapid learning health system as a concept, as a set of values, and as an approach left no key informant indifferent or almost. So I'll share some of the views of the key informants that we've interviewed about this idea of creating rapid learning health systems. As a fifth insight, I also share the views of citizens regarding rapid learning health system. And although it's a concept that's not necessarily very tangible for citizens, they seem to see it as a very common sense approach, and they see it as a way how the system should be working. The sixth insight relates to the word rapid, and you see I'm using the concept of a rapid learning health system. And perhaps the word rapid was the most contentious in this project. And I'll talk about the mixed views about rapid, but also explain that it's about bringing us further and faster together. My seventh insight is that the list of engagement assets in Canada and abroad is remarkably rich, and there's so many things that we can leverage. However, there's still some many gaps and challenges that remain if we want to leverage these assets. Insight number 9, this is from a friend of mine and a colleague of mine, Caroline Canfield, who I thought made a great point here, is that patient advisors, or some call them patient partners, but patient advisors are agile and resourceful connectors over silos that frustrate transformation. So there are many silos between the health system and the research system. There are many silos across the different levels within the system. There are many silos in the research system itself between all different disciplines. And I believe, and Caroline believe, that patient advisors can really help to connect and bridge all these silos. And lastly, I'm just going to briefly talk about the ongoing reform in Ontario, and that it is actually a natural laboratory for citizen and patient engagement in rapid learning health system. And it's currently on the way, and they really put front and center patient engagement, citizen engagement, caregiver engagement, and also community engagement. And I think we can probably learn a lot from this ongoing reform. So let me go back and talk a little bit more in detail about each of these insights. The first one, which is a definition of rapid learning health system that must be anchored in the needs, perspectives, and aspirations of patients. So when we defined rapid learning health system for our project, it was based on the views of the key informants, based on guidance from our steering committee and advisory committee, and also based on existing literature on the concept of learning health system. We identified a series of key characteristics for a rapid learning health system, and here's our definition. So by rapid learning health system, we mean the combination of a health system and a research system that is anchored on the patient needs, perspective, and aspirations, and focused on improving what we know as the quadruple aim, so that we want to improve their care experiences and health at manageable per capita cost and with positive provider experience. So right from the start, we decided to put the role of patients front and center in the rapid learning health system. Another characteristic is that it's driven by timely data and research evidence. It's also supported by appropriate decision supports, and also aligned governance, financial, and delivery arrangements. So all the different parts of the system must work well and be coherent and aligned. So who's making the decision, how the money is spent, and how the services and care is delivered should all be aligned perfectly. And lastly, it's a system that is enabled with a culture of and competencies for rapid learning and improvement. As my second insight is that engagement must be deployed at all levels. So the rapid learning health system can also be deployed at not just at the system macro level, but also at the micro level, at the meso level, and across different sectors. And when we look specifically about engagement, it should also be deployed at all levels. So patients should be engaged in their own health, in their own care, in the organizations that deliver care, in the organizations that oversee the professionals and other organizations in the system. They should also be involved in policy making and also in research and education. And we need to find a way to build capacity to engage that patients can be engaged in all of these levels. Third insight is that we need everyone to make it work. And in the past, and I'm speaking here from the experience in Quebec, which I've studied a lot when I was a young student at university, past reforms have often been some sort of a hesitation. So we were hesitating between engaging patients or engaging citizens, and there was this back and forth between patient and citizens. And PG Forrest wrote a report almost 20 years ago saying that over the years, there was this kind of pendulum movement that has been established between patient engagement and citizen engagement, betraying the hesitations of makers regarding the role and place of engagement in our publicly funded health system. And in Quebec, it was quite evident because we would have one year we would establish a new reform, we would create a lot of citizen engagement initiative and opportunities, for instance, at the regional level. And then 10 years later, we do another reform where now we're focusing on engaging patients. And then probably in another 10 years, we'll do a completely new reform to focus on engaging citizens. So this hesitation waltz kept happening. But what we realized from this project on rapid learning health system is that we shouldn't choose between citizen and or patient engagement. We need to engage everyone. We need to engage actual patients, so those that are receiving care in the health system as we speak. We need to engage potential patients, those who need care, whether or not they are receiving it now. We need to engage families and caregivers who are caregivers to these patients or to potential patients. We also need to engage citizens, by which we mean all Canadians, by the way, whether they are taxpayers or voters, and regardless of their formal citizenship status, and whether they may also currently be considered as patients. These citizens should have a voice in the rapid learning health system about how and what kind of improvement should be made. And also we need to engage communities, by which we mean groups of citizens, whether defined by geography, by lived experience with particular conditions, or with different treatments. We are talking about ethnocultural groups or other types of groups, other factors. And these communities should also have a voice in a rapid learning health system about what type of improvement should be made in the system. Insight number 4 related to how this idea of a rapid learning health system was received, especially with key informants that we interviewed. As a reminder, we did about 50 key informant interviews as part of this rapid synthesis. And overall, the concepts and frameworks and values of rapid learning health system resonated with several ongoing initiatives across the country. A lot of people talked about what was happening in Alberta with their strategic clinical networks, what's happening in New Brunswick also with similar strategic clinical networks, where they're trying to implement this rapid learning health system approach. They talked about things that were happening in Ontario at the regional level, but also across different sectors. So for many of the key informants, it really resonated. But for a minority, they expressed concerns or even skepticism with this idea of a rapid learning health system. One of the skepticism is that, well, we don't necessarily work as a system as we speak, so we don't have a system. So how can we be a rapid learning health system? Others would say that, well, we already learn, so why do we need this? And others, which was a bit surprising, actually one key informant specifically mentioned that we do not need patients to learn. We can do all that without any patient engagement. So this idea of having a rapid learning health system Overall, most people were enthusiastic, although it's important to mention that others were concerned, were skeptical, and especially skeptical about the role that patients could play in such a system. And over the past 2 years, we've also explored this idea of a rapid learning health system in many of our projects. So we, at the McMaster Health Forum, we run many citizen panels on various topics. Could be just recently we're working on a citizen panel about how can we improve hospital to home transitions. We recently did a panel about supporting people living with HIV and so on. And in many of these panels, we talked about this idea of having a rapid learning health system. And generally speaking, most of the participants in these citizen panels view this as a common sense approach. And let me talk a little bit about that. So as we run these panels, one thing that needs to be mentioned is that rapid learning health system, it's not necessarily tangible for most people. So certainly we need to find ways to convey what's a rapid learning health system in a very, very concrete, in a very, very tangible way, so that it can, people can support the idea and implement it. Second thing is that when we explain what's a rapid learning health system to citizens, they said, well, gee, yeah, it's a common sense approach. We need to do that as a health system instead of trying to reinvent the entire health system every decade. We need an approach where we can learn rapidly and make improvements rapidly instead of waiting every 10 years for a big health system reform. And also what seemed to be very appealing to citizens is that a rapid learning health system, for them, it would be a system that allows to build on small innovations and local innovations that can be grown into larger initiatives. So why can't we learn from those small scale local initiatives and rapidly scale them up and spread these types of initiatives? And they say that working like that would seems to fit better for political cycles that also function on short timelines. The sixth insight related to the word rapid. So it was probably the most contentious word in the concept of rapid learning health system. As I mentioned earlier, the idea was to indicate that by rapid that we wanted to bring us further and faster together. But let me share you some of the views about the word rapid. On being rapid, so one area where there were marked differences of opinion was in the use of the word rapid. There was a lot of skepticism, especially among key informants that learning and improvement would ever happen rapidly. Also, they often compare and contrasted this idea of being rapid versus this constant feeling of urgency in the health system right now. And for them, the word rapid meant working at an even more frantic pace. And to some key informants, they were a bit worried about that. For others, they said, well, yeah, perhaps we need to work rapidly, but that should never compromise the quality of data, the quality of research evidence that we generate. And another source of concerns about the word rapid is if we're working rapidly, how can we meaningfully engage citizens and patients? So again, that came up a few times during our projects. We need to find meaningful ways to engage citizens and patients, and how can we do that if we work in a rapid pace. So taking all these comments in the projects, we kind of realized that we needed to clarify that the aim of the rapid learning health system is to learn more rapidly from our mistakes and successes. And we wanted to showcase the need, or to illustrate the need, to close the 17-year gap between the production of scientific evidence, and the patient care. So as I mentioned, we wanted to bring us further and faster together. And one member of the writing team for the project put that, I think said it very clearly. I think the word rapid, it's pretty relative. It should happen faster than the glacial pace of learning and improvement we have now. And when we presented that to our panelists during the citizen panels, I think it resonated. That we don't know, it's not the idea of rapid working in at a rapid pace and at a frantic pace. It's just that we want to learn more rapidly from our mistakes and successes, and that really resonated during our citizen panels. Now, moving on to the 7th insights, the list of engagement assets is remarkably rich across the country, and even in smaller jurisdictions like New Brunswick, Nova Scotia, PEI, there are so many initiatives underway to support greater citizen and patient engagement. And I couldn't do justice today with a single slide to describe everything that is currently being done, all these assets that could be leveraged in both the health system and the research system. But just to give you a sense of the types of initiatives that we have across the country right now. We do have initiatives to support citizens and patients in their own health. For instance, at McMaster, we have a website called the McMaster Optimal Aging Portal that provides evidence-based information that can support healthy aging. We also have initiatives to support patients and caregivers in their own care. We have many initiatives to scale up shared decision-making. We just have a project right now with France Légary's team at the Laval University in Quebec City, trying to scale up shared decision-making. We have groups like at the Ottawa Hospital Research Institute who have a repository of decision aids to support patients making decisions about their own care. We have decisions toolbox, we have patient portals, so many initiatives to support them in their own care. We also have initiatives to support patients and in the organizations that deliver care. In Ontario, we have those patients and family advisory councils, for instance. We have many organizations also supporting organizations that oversee professionals and other types of organizations in the system, like Accreditation Canada, for example, that has a patient partnership framework now. We have initiatives to engage citizens and patients in policymaking. I often mention the citizen panels that we're running at the McMaster Health Forum. We have a lot of organizations like Health Quality Ontario that has developed tools, frameworks to support greater patient and citizen engagement. We have same thing in the research field with the SPORE initiatives. We have also recently worked on an evaluation toolbox, which was published by the Center for Excellence on Partnerships with the patients and the public. It's an evaluation toolbox that is basically a repository of all types of evaluation tools, guide, questionnaires that can be used to assess, evaluate, and appraise public and patient engagement. And also we have lots of initiatives to engage patients and patient advisors and partners in the field of education. We can simply mention what the work being done at the University de Montréal, or even at the University of British Columbia. I spoke earlier about Caroline Canfield, who has an appointment position at the UBC to promote greater roles for patient advisors in the education of health sciences students, for instance. So the list of engagement assets is really rich. There's so many things being done right now, but still, and I forgot to mention also something that's quite important as part of the list of engagement assets. We see something which is incredible, is that we see emerging organizations led by or co-led with patients, like the Patient Advisors Network, which is a Canadian network. We have the Patients' Voices Network in BC. In Alberta, we have Imagine. It's a group of citizens collaborating for health. We have the group in Montreal, the Center of Excellence on Partnerships with Patients and the Public, which is co-led by Vincent Dumais, who is a patient partner and a patient advocate. And also we have lots of engagement assets at the international level. Just to mention what's being done at the International Association for Public Participation. In the US, we have PCORI that supports patient engagement and patient partnership in research. We have a lot of initiatives in the UK, such as Involve, that supports public and patient engagement in research. We have James Lynn Alliance and so many other organizations involved in supporting citizen and patient engagement. But there's still a lot of gaps and challenges that remain. And what we've seen from our rapid synthesis and what's currently happening in Canada is that patients are not often being meaningfully engaged in prioritizing what we call the needles to move. So what should be done? So in terms of the care experiences and outcomes that are priorities for rapid learning and improvement. So not a lot of engagement in setting these priorities. And also we realize that patients don't have many mechanisms beyond complaints and voting to register their frustration when needles don't move, when the system don't change or don't change as rapidly as they would hope. And another big challenge is that we do struggle to connect all the assets, the engagement assets across the country. And that's taken, the slide draws from the work of Julia Habelson, who presented at the first International Summit on Patient and Public Partnership a few months ago. And Julia pointed out that there are a lot of challenges to connecting and leveraging engagement assets across the country. So there's a lot of engagement work being done, and however, it's driven by different motivations, different mandates, and different communities of interest. Also, there's a lot of overlap, blurring and fragmentation, which can generate some confusion and duplication of efforts and burden also for some patient partners and a drain on already scarce resources. So, and we've seen that, and I've heard a few patient partners and patient advisors mentioning the burden that they feel being overwhelmed, being engaged in so many different initiatives, that it proves to be quite challenging for them. And also Julia pointed out that there's little political will currently to address this. And where might it come from? What might catalyze this desire to connect and leverage engagement assets across the country? So that's something that seems to be currently missing. Moving on to the ninth insight, patient advisors are agile and resources connectors over silos that frustrate transformation. And that comes from Caroline Canfield. She did a presentation a few months ago about her perspective on citizen engagement in Canada. And I thought it was a brilliant point that patient advisors or patient partners can really act as connectors and bridge the different silos in the system right now. And Caroline pointed out that already patients, families, and citizens are connecting up with each other in peer networks to develop their own capacity and skills to be better engaged. So they are already quite engaged among themselves. I've mentioned earlier different groups like Imagine Citizens in Alberta, the Patient Advisors Network. So these are quite great examples of networks created by and for patients and citizens. And also, Caroline indicated that patient advisors were seen as being able to play really a leadership role to bridge silos, so both the vertical and horizontal silos in the health and research system. And also that they can actually facilitate or trigger action. when nothing is moving, when the needle doesn't move, they can facilitate or trigger actions. They can offer guidance on how to move forward. They can identify potential solutions that are socially, politically, and ethically sound. They can help us to mobilize stakeholders and so on. And to conclude, insight number 10, talking more specifically about the ongoing reform in Ontario as a really natural laboratory for citizen and patient engagement in rapid health system. And what's interesting is that when they announced the reform, there was a bit of a mixed feeling. So when we spoke with patient advisors and citizens, they were a bit skeptical about what would happen. But among providers, among researchers, they are actually quite enthusiastic. And what seems to be interesting particularly is that they try to bake in this idea of a rapid learning health system right from the start of the reform. So one key aspect of the reform is the creation of these new Ontario health teams. And these health teams will need to learn rapidly from their contributing partners and from other Ontario health teams and from those who've succeeded and failed in similar work outside of Ontario. So that's something that they need to do as they develop their own Ontario health teams. And over time, the objective is that each Ontario health team will become a microcosm of a rapid learning health system, as well as contribute to the broader Ontario's health system, which will also become a rapid learning health system. So as you can see in the reform right now, it's already baked in this idea of a rapid learning health system. But not only that, they really put front and center the need for patient partnership and community engagement. So I see it's a bit fuzzy right now on this slide, but this is taken from a document describing the building blocks of these Ontario health teams. And the third building block is actually patient partnership and community engagement. So Ontario health teams will need to demonstrate a history of meaningful patient, family, and caregiver engagement. It will need to demonstrate support from First Nations communities where applicable. You need to put in place a plan to include patients, families, and caregivers in all their governance structures and put in place patient leadership. They also need to show a commitment to develop an integrated patient engagement framework and patient relation processes. And you'll see in the second column, these are the things that they should think about when they develop their Ontario health teams. So they need proactive patient public engagement, could be in the service or program design, could be at the organizational level, for instance, advisory councils, leadership and governance structures. And you also need responsive patient relations, including complaint mechanisms and other type of unstructured feedback. They need to include patient values, including the Declaration of Values that was developed by Julie Drury in Ontario. They need strategies to engage communities, so not just individual patients and citizens, but broader communities. They need to have a plan to engage Indigenous population, and also think they think in their framework clearly about ethno-cultural sensitivity. So it's going to be interesting to see. The Ontario health teams are just at their first initial stages, but we'll see how these small, rapid learning health system will be able to engage citizens, patients, and communities over the next couple of years. So this is it for my top 10 insights about rapid learning health system. Just want to acknowledge the contributions and work of all the authors and contributors to the rapid synthesis that was produced by the McMaster Health Forum. I want to thank the CRHR Institute for Health Services and Policy Research and the Canadian Health Services and Policy Research Alliance for their financial support. Also the Alliance Working Group, including Tom Noseworthy, Denis Roy, Rob Reed, and Diane Finegood, and also all my colleagues at the forum, all our collaborators who did the jurisdictional scan and the key informant interviews, including John Lavis, Christina Matheson, Kalen Mowat, Gary Waddell, and Mike Wilson. So for those of you who are interested in this rapid learning health system approach, we have a series of documents that are available on the McMaster Health Forum website. I've listed the URL here. There's the rapid synthesis about creating rapid learning health systems in Canada. We have a very short, brief primer on rapid learning health system. And also we have some specific documentation to support Ontario health teams who want to implement this idea of rapid learning health systems. So thank you so much. And I'll turn to the chat box and to Stephen to see if there's any comments or questions. Thank you very much.
Great. Thanks, FP, for a great presentation and a really good overview of what the importance of patient engagement, and as well as some of the challenges about achieving that. So for those of you on the webinar, if you have any questions or comments that you'd like to share, please use the chat box sort of on the bottom right of your screen. In the meantime, I'll just reiterate, so McMasterForum.org is our website where you can find a lot of the materials that FP mentioned. If you're interested in more of the materials around the Ontario health reforms created by RISE, the website you can use to go to that directly is OHTRISE.org. All right, so we have a question here, FP. So the first question is how did you demonstrate the effectiveness of rapid learning health systems for health outcomes? Are there any data?
Yeah, that's a good point. And I would need to refer back to the rapid synthesis, and there wasn't many actual studies looking at the effectiveness of these rapid learning health systems. So most of the literature now talks about potential success factors, implementation considerations, or broader principles that should guide the development of these rapid learning health system. But certainly this is probably one of the missing links. So we need to try to find ways to assess and evaluate and appraise the effectiveness of these rapid learning health system in improving patient outcomes. And I think Stephen just posted the link to the actual rapid synthesis. So if you click on the link, you'll get directly to the web page describing the rapid synthesis report. And you also have, what's interesting, you also have appendices, 14 appendices actually, one for each jurisdictions that we run a jurisdictional scan. So if you're interested to see if there's any interesting assets and gaps in Alberta, Nova Scotia, or at the pan-Canadian level, you'll have a specific appendix for that.
Thanks, FP. That was a much better description than I was going to provide. So that is excellent. But yes, the link is there for those of you who are interested in checking out the rapid synthesis that FP was talking about. Doesn't look like there's any more questions coming in right now, but if anybody, oh, sorry, I spoke too quickly. So is there applicability of rapid learning health systems to health systems internationally, for example, low and middle income countries working on universal health coverage?
Interesting. I should look into that. I believe for the purpose of the rapid synthesis, there was a specific focus on developed countries. So I could probably run a search to see if there was a specific literature on rapid learning health system, specifically for low and middle income countries. So that's something I should be more than happy. So if you'd like to send me your contact details, I could rapidly run a search to see if there's anything specific about low and middle income countries. Yeah. So for the purpose of the project, we really looked at a context more similar to the Canadian context.
Great. Okay, so I don't think there's any other questions that have come in, but we appreciate everybody for joining us. Everybody who's joined us today. We do have more top 10 webinars coming up in the next month. We have one in November on the role of intermediaries in supporting systems change, and then a webinar in December on supporting the use of research evidence to inform decision-making in crisis zones. And we'll have more webinars next year as well. So we encourage you to go to the forum site, check out the webinars there, and register for those that might be of interest to you. And we hope that you'll join us for some in the future. Thanks again to FP for sharing his insights with us today. And thanks everybody for joining us. Have a great day.
Thank you.